Good morning, dear colleagues. I welcome you to this panel discussion on pharma's path to recovery and the new normalcy. At the outset, I would like to thank the CPO Innovation Group for organizing this meeting and for their kind invitation to me to moderate the discussion. The Covid-19 pandemic has disrupted normal life as we know it, and also businesses everywhere. In an attempt to contain the virus and limit the spread of the disease, countries and governments have imposed lockdown. This is hopefully only temporarily the new normal. There has been a suspension of business activities under these circumstances, and as you know, pharma and healthcare partnering with doctors and patients cannot be suspended. I am Dr. Rashmi Hegde, Vice President Medical for Cipla Limited. I'm a pediatrician by training and have 2 decades of working experience with hospitals, healthcare and pharma companies such as Abbott, Solvay and Novartis. My areas of interest include precision medicine, machine learning, artificial intelligence in healthcare, as well as real-world evidence, translational medicine, and its application to clinical studies and new product development. I would now like to invite my distinguished co-panelists to join the discussion and introduce themselves. So to begin with, I invite Mr. Gautam Khanna, CEO of PD Hinduja Hospital, Group of Hospitals and Medical Research Center, India.
Thank you.
Welcome, Mr. Gautam Khanna.
Thank you, Dr. Rashmi, and thank you, CPO Innovation, and good morning to all the viewers. I am Gautam Khanna, and I have spent over 30 years in the healthcare industry. Last close to 7 years have been, 6.5 years have been in the hospital space, while over 22 years have been spent in the medical device industry as part of 3M. And I worked in India and international in 3M, and I was responsible for South Asia for healthcare business before I joined the hospital business. And I look forward to the interesting discussions today. Thank you.
Dr. Gaurav Thakral, who's the Executive Vice President and COO of Healthcare at Home. I invite you now. Welcome.
Thank you, Dr. Rashmi. Thank you, CPO. Good morning, everyone. I represent HCH and the home healthcare industry in the country. I have experience of around 20 years. By training, I am an intensivist. I have worked with Fortis into various roles for 10 years, where I was last director for their hospitals. We pioneered home healthcare in the country 8 years back, and now I represent an industry which is very, very quickly evolving, getting acceptance, and is publishing its outcomes. Thank you for inviting.
Mr. Badree Narayan Shrikhan, who is the Group CFO at Star Care Hospital, Oman. Welcome, Badree.
Thank you, Dr. Rashmi, and thank you, CPO Innovation, for giving me this opportunity. Good morning to you all. I hope that you're all doing well. I am Badree. I work for a hospital called Star Care in Oman. So this hospital is predominantly based out of Oman, and we also have a medical center in Sharjah, and we also have a 250-bedded hospital in India as well. I have about 18 years of experience in the field of finance and accounts, and I'm a chartered accountant by profession. And I have about 9 years of experience in healthcare. I have worked in companies like Airtel, which is into telecom. I have worked in Wipro, which is into FMCG, and also a couple of hospitals in India, which is in Bangalore and in Chennai. And now I'm in Star Care, Oman. I would like to start this session. With a very positive thought. I would like to start with a quote from Bill Gates. I hope you managed to read an article written by Bill Gates last week, which specifically spoke about vaccines. So India has the capability to produce vaccines for the whole world. When I read that article, this was very heartening to see that, and I hope that this is coming anytime soon. Thank you for the opportunity.
Okay, next is Mr. Deepak Mansukhani, my colleague from CIPLA, who is a Senior Director, Strategy, Business Development and Alliances at CIPLA.
Thanks, Dr. Rashmi. Good morning, all of you, and great to see all of you. Thank you to CPO Innovation for inviting us to this discussion. I have about 15 years total experience, of which 12 years are with pharmaceutical industry. I've also spent some years with management consulting firms doing pharma projects, including with Accenture and BCG. I currently lead the strategy, business development, and strategic alliances for the international business of CIPLA. I've been closely following and been part of the COVID initiatives on behalf of the company, and glad to hear some thoughts and share some ideas with this distinguished panel. Thank you.
Great. Mr. Satya Sundar Madateri, who is CEO and Director of LifeTech Scientific India. May I welcome you to this discussion.
Uh, uh, Hello, everyone, and thank you, Dr. Rashmi. At the outset, I would like to thank the organizers, the CPO Innovation, for arranging this very relevant session, I think, and giving me this opportunity to be a part of the team panel. I'm Satya Sundar Madateri, currently working with Life Scientific India Private Limited, that's CEO and Director. We are into implantable medical devices, especially in the cardiac and peripheral segment. I have around 27 years of experience in the healthcare business, out of which 17 years into the medical devices like Abbott, St. Jude Medical, Medtronic, dealing with the different cardiac implantable. And prior to that, 10 years with the pharmaceutical selling with companies like Pfizer, Abbott, and I have gathered experience through working in the various roles right from the medical representative and moving up. And for the past 9 years, I've been into strategic operational role as business unit head and the country manager, earlier with St. Jude and now as the CEO with the LifeTech. I've been handling the South Asia market, consisting of Pakistan, Bangladesh, Nepal, Sri Lanka. Medical device business being a rapid, evolving, and a highly competitive business, adoption and integration of the technology into the business has been a key priority. I think we see medical device companies as strong partners working to help the overall improvement of the healthcare in the country itself. And a lot has to be invested back to build on therapy accessibility and the skill building among the physicians. I'm happy we could achieve a lot towards this in my previous organization as well as the current one. And today I look forward to this very informative and informative session.
Thank you, Satya. Mr. Indranil Roy Chaudhary is next. He is President and Head of Pathology Business at Medall Healthcare. Welcome, Indranil.
Good morning to you, Dr. Rashmi, and my distinguished panelists, and a very good morning to all the participants for this discussion. Myself, Indranil, I'm basically having about 25 years of experience in the healthcare space, out of which last 6 years have been in medical diagnostics. I have led P&L role in SRL Diagnostics for a long time, then served Diagno Labs as the Chief Operating Officer, currently as President and Head of Pathology for Medall Healthcare. Prior to this, I have spent about 19 years with leading pharmaceutical companies of the country, including Novartis, Sun Pharma, Zydus, and Torrent, to name a few. I am looking forward to a very fruitful and interactive discussion today with all of you. Thank you.
Thank you, Indranil. And last but not the least is Ms. Mayurakshi Ray, who's the Chief Compliance Officer at Gibbs Healthcare Solutions. Welcome, Mayurakshi. Mayurakshi, you're on mute. Unmute yourself.
Hi, can you hear me?
Yes, now we can.
Hi. Okay. Good morning. Sorry for that. Good morning to everybody. Thank you, Dr. Rashmi, and thank you, CPO Innovation, for first choosing a very relevant topic and then giving us the opportunity with a distinguished panel to take up a topic that is very relevant and a sector that is very relevant in the circumstances and to see how the sector moves. I have about a little bit about myself. So I have total about 20 plus years of experience into management consulting, into the industry. I had always worked in the risk compliance and information security and the cyber security space. I have worked with a lot of pharma companies, both in my consulting capability as well as in the as an industry participant. So currently, I am with a company that caters completely to the US healthcare industry, and I'm happy to learn from this session as well as share my thoughts. Thank you so much, and look forward.
Thank you, Mayurakshi. And with that, let us dive straight away into the panel discussion. Uh, so first, at the beginning, at the outset, let us talk of the healthcare environment today, which has been part of the lockdown. At CIPLA, we have worked very hard to keep our factories open, even under lockdown, so that essential medicines can be delivered to patients. I'm hearing a slight echo. I think those of us who are not speaking, can we just turn off our mics? Thank you so much. So our sales teams have been very successful in reaching out to doctors and hospitals digitally so as to make available the essential medicines, including the COVID medicines. So what, in your view, have been the challenges faced by patients in the last few months? I would like to address this question to Gautam Khanna, to Badree Narayan, and to Indranil from the Diagnostic Perspective. So Gautam, would you begin?
Thank you, Dr. Rashmi. So I just want to say that in the last few months, it has been quite a tough time for the patients. I mean, there's a lot of fear, there's a lot of anxiety, and especially since not many people knew what is going on with COVID. And you would hear stories about COVID and whether hospitals are able to treat, and international stories of how, I mean, what was nightmare. But so specifically coming to that, the biggest challenge was when people realize that they are COVID positive, they don't know what to do. So, for example, they don't know where to go, whether their bed is available or not. And initially, the private players and the government, we were all trying to develop the protocols. And now I'm happy to say that those protocols are developed. So now, of course, there's a clear guideline and as to who gets admitted, who stays at home, and what is the process. Especially in Mumbai, there is a coordination number, so the patients are allocated beds as per that. So those things are streamlined, but that was a big issue. The other issue is the non-COVID patients. They have actually suffered a lot because
Yes.
I mean, COVID came, but non-COVID diseases didn't go away. But since many hospitals were forced to convert to fully COVID or partially COVID, there's a lot of fear and patients don't know whether they should go to the hospital. Doctors were also trying to figure out what is the protocol for procedures and surgeries, because for COVID patients, the mortality rate is high. So what should be done? So those fear, and plus the hospitals were trying to do a lot of these changes to meet with COVID. For example, infrastructure change of negative pressure, getting PPE everywhere, getting safety protocols, sanitization, masks, and getting social distancing done in the hospitals. So all these things were being done. And when patients would hear, and I must say this here, that actually patients should be happy that this is being done. So they should feel much safer in a hospital where these things are being done compared to the place where they know that they're not hearing anything. So I that was a big concern. And the other thing, I think, what happened was there were, suddenly many people were, the businessmen and some other people were out of cash. Cash means they didn't have regular monthly income. So once that happens, there is a slight uh, anxiety in people, and they don't want to spend. So if they want to postpone, they will postpone, and things like that. And they're also scared about whether how much money it will cost. So there is a lot of pressure on the costs. So that also happened. And many services which we were offering at home, for example, through our care at home, we were offering, like physiotherapy and nursing and all that stopped. And that stopped. So many people who were geriatric patients, or other patients who needed care at home, so they were also affected. So overall, there was an environment of fear. They were scared, and they didn't know, due to lack of adequate information, they didn't know what to do. And but now I'm happy to say that all the guidelines are in place, all the protocols are in place. And hospitals also, including ours, we were the first ones, I think, to in Mumbai, to stop our OPD services and indoor services for patients. And Mr. Modi later on declared, after a couple of days, that it should be stopped. But when you stop that, there was the patients, without knowing, they didn't know why we had stopped, so they thought something is wrong. And so there's a lot of concern, but we have been able to address that. So I'm going to stop that and wait for your comments.
Great. Now, Badree, do you want to say something? Do you want to add something from the hospital perspective?
Yeah, thank you, Mr. Gautam Khanna, for your insights. I might have to repeat some of the things that Mr. Gautam had told. Similar experience we also had in Oman as well as an hospital in India. In March 2020, when COVID broke out, obviously in March and April it spiked a lot. At that point of time, the patients were not coming to the hospital at all. Obviously, this has something to do with fear and anxiety. And more than that, there were a lot of information that was floating around. So there were a lot of information, and to add on to it, there were a lot of misinformation also, because people were not able to first understand what is this pandemic. People were not able to come into terms. In fact, many patients who are coming to our hospital started behaving differently, started behaving in a very aggressive way, because there were new rules, there were new guidelines. It was difficult. So just to share some experience of our hospital. For example, just to throw some numbers, we used to see about 2,000 to 2,500 outpatients a day. And suddenly in March, this went down to 300 to 400. And this was like a 70% down from the current number, which was so surprising for us. But we were not able to address it, except that we were able to create some awareness around it. We were able to give some information around it. So one thing we were able to do is we thought that we should go back to the basics. So thanks to NABH, the National Accreditation Board, which has set some protocols, clinical protocols. Internationally, we have something called JCA, which is Joint Commission International. So those are the documents which we have to go back to ensure that the basic clinical practices are already in place. For example, the doctors have to be protected. First of all, the internal environment has to be safe. So, for example, the doctors have to be protected, the nurses have to be protected. So, taking into account the doctors, we have to provide them adequate PPE, we have to provide them masks, all those guidelines were there. Then, obviously, when it came down to May and June, slowly, when a lot of information, as Mr. Gautam said, in terms of guidelines, so people were slowly coming into terms, and then people have started visiting the hospital now. So I would like to say that still we have not come back to the normalcy in terms of going back to the 2,000, 2,500 patients a day, but still we are able to move towards the 1,500 plus patients a day with whatever protocols we have set. Yes.
Great, thank you. Indranil, would you like to add something from the diagnostic perspective?
Yeah, I think both Mr. Khanna and Badree have added the challenges faced by the patient. See, from the diagnostic perspective, in today, 70% of the decision on a treatment protocol depends on a diagnostic test. And so the importance of a diagnostic test is immense. And in the COVID times, the biggest challenge patients faced was the interface between the patient and the tests to be done, whether you do it in a hospital setup, whether you do it in a standalone lab setup, that got disrupted significantly. So this is not only, for the COVID, of course, on the COVID, people had a lot of question, which person to be tested. People who are just having fever for a day or two wanted to be tested. The states had different protocols. Some states said you need a prescription. Some said you don't need. So there were a lot of pandemonium, lot of chaos lack of clarity that existed in the beginning, because obviously no one expected this situation. The clarity slowly came, but also I think along with COVID, the biggest challenge also was the chronic as well as the acute diseases which are already there. As Mr. Khanna said, COVID came, but other diseases did not go away. And many of them require routine checkup, whether it is your thyroid, blood sugar, whether it is other diseases like dyslipidemia and all, as well as the acute phases. So there was a lack of clarity. There was no interface between the patients and the diagnostic service providers. Those were the major issue. Added to that was an issue which also impacted the patients, was the lack of infrastructure in diagnostic space in our country, whether it is RT-PCR machines, whether it is the RT-PCR kits, or even trained staff. So all these impacted both the industry and hence the patients. So these were the challenges. I will come in the course of the discussion moving ahead. What is it that the industry did and what is it helped, and what is the current status? But as of now, let me stop here and let the discussion move forward.
Thank you, Indranil. We all agree on how imperative it is for pharma, for hospitals, for healthcare services, which includes both diagnostic, therapeutic, delivery of medicines, delivery of devices, home healthcare, to continue to function fully in the best interest of the patient. And as you all have mentioned, we have come a long way since March 2020. So what are the new operating models for pharma and healthcare, which are both affordable and accessible for patients, and how to make this possible? Is there a collaborative approach that healthcare institutions can follow to bring down the costs of healthcare, which, as Gautam Khanna mentioned, is an imperative at this point in time? So I would like to address this question to, again, Gautam, Badree, and Deepak.
Dr. Rashmi, it's a difficult question, if I can say, because if it was easy, somebody would have answered it by now, so obviously. But having said that, I think it is important to understand that we need to have this collaboration among all the players, and it is currently, I have to say, there is informal arrangement. Like, for example, I mean, I talked to you, Dr., with your company, and we talked about it, and we've spoken to some other companies. So we have informal discussions and try and give a solution to the patients in time as per their need. But I think the way forward is that it needs to be structured in a manner that there is some kind of a integration across the layers, and maybe in the horizontally also among other hospitals and among the suppliers, so that we give a kind of a package or something which is a patient-centric thing. Right now we are doing a medicine-centric or a hospital-centric thing. So that is one. Second thing I think is the insurance companies need to play a bigger role in this, that they need to encompass the full continuum of care. That means whether it is OPD, whether it is home care, whether it is hospitalization. So everything when they talk about, then and the cost of medicines, of course, because some medicines they exclude. So they need to put everything together, and this collaborative thing will work. Now, I don't have an answer to it, but the only thing I can say is that more and more we use, and I heard you talked about machine learning, the more and more we use artificial intelligence, some data analytics, to understand where are the bottlenecks. Maybe supply chains can be made shorter. Maybe we can make it a little more, customizable, if I can say that. And so that I think is some of the thoughts, but I will let my friends here talk a little more.
Badree.
Thank you, Mr. Gautam, again for your insights. So let me segment this question into two parts. Let me segment the different services that the healthcare provides to the patient. So one in terms of outpatient consultation, second in terms of inpatient admissions, third in terms of pharmacy delivery, and fourth in terms of lab and investigations. So these are the four different segments where the hospital industry, hospital healthcare provides to the patient. So as far as outpatient, pharmacy and lab, obviously there are models which are evolving. I would like to say that 30, 40 years back, the doctors went home and visited the patient. And now we are talking about the same home healthcare where the patients are visited by doctors at home. So in terms of the home healthcare evolving a lot, this will clean up a lot of logistics in the system in terms of visiting the patients at home. Then the second is in terms of the teleconsultation, where the doctors can consult the patient at ease from the doorstep for the basic consultations. And obviously, the required prescriptions can be delivered at home, and the required basic lab tests can be collected from home. So, from this aspect of it, the outpatient pharmacy and the lab can transform into new models, but obviously, this has not taken full shape. Obviously, Mr. Gautam told that the insurance company should support on this. The government should also play an active role on that, and this is bound to happen. In terms of inpatients, obviously, we have to still figure out a model, because when it comes to inpatients, you have two segments. One is patients who get admitted for emergency. Obviously, we can't go home and treat those patients. Second, in terms of elective cases, surgery. So these are the cases which are bound to come to the hospital. So obviously, these are things which are still at an existing status quo, and I'm not sure if there are any new ideas which will come in future. Technology might play a role. Google is getting into AI, and a lot of things are happening around it, but we have to wait and watch for this to happen. The second important question, which is very interesting in terms of how do we bring down the cost to the patient? See, today, the biggest complaint that the patient has is the price that we are charging is very, very high. Fortunately or unfortunately, everybody thinks that healthcare makes a lot of money, but actually it is not the case. If the price that we charge to the patient has to come down, the cost that is incurred by healthcare has to definitely come down. If the cost that is incurred has to come down, we have to look at definitely new evolving models. Let me give you an example. I am seriously thinking about of a mall kind of a model. A mall, obviously not an expensive mall, which is in Bangalore. It is a basic mall wherein everybody starts collaborating. This is the time where the private healthcare players needs to collaborate. In healthcare industry, the biggest element of cost is manpower cost, which is basically the cost of employing the doctors and the cost of employing the nurses and other back-end operations. The time spent versus the money that we spent, this has to be looked at in detail. Let's take a situation today where this has already happened in bank and telecom. A HSBC customer goes to Standard Chartered ATM and he withdraws money. A Chennai customer goes to Delhi and logs into Vodafone network. So all these things are happening. So in healthcare, probably in next 10 years, healthcare will become the next bank, or healthcare can become the next telecom, wherein we all start sharing resources. So that is my dream in terms of how we can share resources. For example, you create a mall kind of a setup where you have different specialities. For example, one hospital could be good in one specialty, the other hospital could be trained in other specialty. The nurses can be shared, the back-end operations can be shared, a lot of information can be exchanged. See, 2020 is the year, this is not the year to make profits. This is the year to sustain. So it is important that we think on a larger picture. The private players should all come together, look at not only their profits, first get this COVID out of the way, and then 2021 can be a new start. Thank you.
Good. Deepak, you want to talk from the pharma perspective?
Sure, thanks, Dr. Rashmi. I think it will be an understatement to say that this pandemic has brought unprecedented disruption to the way healthcare is provided, and pharma is no exception. However, I think pharma is one of the few sectors which has the resources and wherewithal to actually deal with the disruption. And you spoke of the new operating models that have evolved, right? So I think in the initial part of the pandemic, especially when the countries were going into lockdown almost on an overnight basis, most pharma companies were in a crisis management mode, where the imperative was to ensure that essential medicines are reaching the end consumer and the various markets. And obviously for that, we needed to adapt our resources and entire operating model accordingly. So just to throw some perspective on how the medicines were actually or are still being actually reached to the end consumer, on the manufacturing front, pharma has had to completely relook at the way network strategy is implemented, right? So we had to rebalance manufacturing capacities between plants. Even within a country, say India, where we have multiple manufacturing sites, each of them was operating under different capacities and lockdown protocols, which meant that we did not even have a 1 month look ahead on how and when manufacturing will resume, and which needed a lot of technical agility on behalf of pharma's workforce to reimagine how manufacturing is done in this environment. In a when half the people are not available at the sites, when quality assurance people are not available to release the test and release the batches. So that needed a lot of, first of all, automation. Second is on capacity reallocation to plants or sites which were more able to work during the lockdown. The other trend or the operating model that's emerging is now pharma is realizing we need to move or shift manufacturing closer to the end markets. This is more from an international perspective where there is so much of regulations and countries are in a wave of self sufficiency, so to say. They are trying to protect their own supplies and manufacturing networks to ensure that healthcare is not impacted for their citizens, right? So pharma companies are now continuously re-looking at the way manufacturing sites are deployed across the world, not just their own sites, but even contract manufacturing sites. So earlier, for example, landed cost used to be the key metric for a CMO for a pharma company. Now I think that is no longer the case. You need to look at a balance of costs and risks. Geographical and geopolitical risks are a very important consideration in your manufacturing network, right? So that's from a manufacturing side. Moving on to supply chain, warehousing has got massively impacted in this pandemic. We needed to automate warehouses, and so that they don't, we are not completely dependent on manual labor. There was a lot of stockpiling being done, and now that is the new operating model where some categories which are going to be in short supply because of this supply chain disruption. For example, APIs, some critical APIs from China. There were some sterile fill finish formulations which was needed to be bulked up in inventory so that the formulations are not impacted. Logistics and air freight was a massively impacted category where pharma companies, right from the start of the lockdown, did not know how the consignment would reach from the manufacturing plant to the depot, from the depot to the port, and then port to the market. Now that has become a completely different ball game now, and we are having to continuously monitor the sea and air freight movements to just to plan and look ahead on how to reach the various consignments to various markets. So these are some of the operating models that are evolving. Now that was on the supply side. Coming to the commercial side, I think pharma's imperative now should be, now that we understand more about the disease and the impact, the I think pharma companies have the resources and the wherewithal to reimagine how patients will be served in a post COVID era. I think we are gradually realizing that it's no longer about promoting individual products to specific doctors and trying to realize the maximum market share out of that. This is the time when pharma companies actually are looking to partner not just between themselves but with the entire ecosystem, because the healthcare needs of all patients are important, especially as COVID patients and non-COVID patients are actually converging. As the pandemic is progressing, a lot of the chronic patients stand a very high chance of developing COVID, and their treatment protocols may get changed, which I think we can play a very important role in understanding. Pharma has the resources to actually understand local dynamics of treatment patterns of the healthcare ecosystem, what the local prescribers are doing. So we can actually be a bridge between various parts of the healthcare system to provide that medical and commercial knowledge and fill in the gap. So this is where the collaboration needs are stemming from. I will stop here and we will share more ideas in the later part.
Great. Thank you all for your perspectives. And I would like to say that I think pharma and healthcare has done a very commendable job in the last few months in making medicines and healthcare available to patients. And Deepak will remember that in the first month or so, we had at CIPLA, we had meetings every day in order to discuss how to keep our factories open and how to make the medicines available. In fact, most medicines were sent through courier, but courier services also were not available. So, air services were not available, and there was a lot of costs that the companies incurred in order to make medicines available in the, most remote corners of the country. So to come to the next pieces, all of you have mentioned this, and that chronic disease and its diagnostic tracking and treatment are very important, and they should not be neglected just because of the focus on COVID. So, how has your organization minimized disruption and ensured that patients with non COVID chronic disease also have access to healthcare and medicine? Have you reimagined the patient experience in hospitals? And how do we create a business model that is a one stop solution for patients that includes consultation, diagnostics, as well as delivery of medicine? So, Indranil, would you like to talk on this? So, Indranil, Badree, Gautam, and Deepak.
Okay, so as you rightly mentioned, for the both for the chronic as well as the acute as well as for the COVID for everyone, the tracking is very important. And since we spoke about, we know that the interface was disrupted. So the question is, how do we provide service? So obviously, ramp up of home collection services is something that everyone looked at. But home collection also has its challenges, because in this particular time where there's a lot of apprehension, a lot of fear in letting in someone else whom you don't know, letting into your house, because home collection, still you have to allow a phlebotomist to come to you and collect the samples from you. So that remained a challenge. However, what we did was certain steps which we used to minimize the contact. So basically, moving on to lot in the apps and the webs. So that was already a movement that was taking place. So that got hastened up. Second is whenever simple steps, like whenever you pay for a home collection, you have to use a credit card machine. Sometimes you use a credit card machine. Even to punch into your credit card machine, the PIN number and all, you need to touch. So how is it that you can avoid that? So just use a link which goes to the patient's mobile phone, and from that link, he pays directly using his credit card or net banking, whatever. The delivery of the reports, instead of giving a printout reports, shifting completely to paperless soft copies, which goes through the app or through the email to the patient. So these are some of the things that the diagnostic industry tried to do as a whole. But however, you said that have we reimagined the patient's experiences? So the challenge still remains that you have to be in physical contact to give your sample. Unfortunately, the patient cannot draw the sample, and we can't use a drone for that sample to get collected. There is a human connect that will happen. So it becomes imperative for the service providers to ensure that the people who are really coming in contact with the population, with the customers, they are healthy and they are safe. So routine checking of our own people, in terms of whether you talk about the RT-PCR or the antigen or the antibody test, as well as the thermal screening and the SpO2 checking, all those, so that those people who are really coming in contact, they are healthy, they are safe, and we do not spread the disease among the population. So these are some of the things we did, and as a matter of fact, I'm sure everyone else did. But when you come to have we reimagined the patient's experience, what is it going to be? I am completely in agreement some of the thoughts which Badree had shared about partnering. And partnering is, as he said, that a HSBC client goes to a Standard Chartered ATM and draws money. So it has to be in the industry, within different organizations in the industry, more so required in the diagnostic field, because unlike pharma, in pharma you see a trend that a company like Cipla or a Sun Pharma, who are India leaders, who lead the business in the country, and they are in 1, 2, 3, they are by and large in every zone, they are present strongly. Diagnostics is not like that. So if I talk about the top 3, 4 companies in diagnostic industry, they are all very strongly present in a particular zone, going very deep into it. In other zones, their presence is very, very scant. So here it becomes very important for every diagnostic company to partner with not only with each other but also with the industry. A person not only requires a diagnostic test, after the diagnostic test, the physician is going to prescribe a medicine. How does he get the supply of the medicine? The physician is going to tell him to do certain exercises. He needs a physiotherapy support to do that. How will he do that? So all that, and there comes the question of, he was talking about a mall, Badree was talking about a healthcare mall. So not only is a mall important because mall people will still have to go and avail the services, it's also very, very critical and imperative that within us we join hands and we think of an evolving model where most of the services can be provided at home. I know Gaurav is a part of this panel today, so we really look forward to hear from him how we can improve, because in our country still a lot of this home health care that we talk about has to go a long way in my view. Even if I talk of teleconsulting, teleconsulting is only a WhatsApp call in our country. So what is the essence of consulting a doctor? The essence of consulting a doctor is the doctor should be able to feel your pulse. The doctor should be able to hear your heartbeats. Then only can he understand what is wrong or what is right in the patient, and then only can he take a decision. We have to think on how those can help. Artificial intelligence, technology are all, we are going miles in those. So we really have to travel a lot many more to evolve with something so that we are able to address those. We have come a long way. I surely believe we have come a significant way, but I think we have miles to cover, and we look forward for everyone's views. We look forward for evolving models, and again, cost has to be very, very important, because we can't afford to have something which only 0.1% of the population can afford. It's not going to help the masses. It's not going to help our country. So I think those are the areas which we need to think moving as we move ahead.
Thank you. Badree, would you like to go next?
Yeah. Thank you, Mr. Indranil, for your insights again. I would like to answer this question in two parts. Obviously, the patient experience has changed. So typically, just to give you a sense, in Oman, we are purely driven by insurance. So the patients who walks into the hospital, we have a lot of paper claims to be submitted. So even the patients are reluctant to sign the documents, sign the paper. So we are now talking to insurance companies to see that whether we can do online submissions. So the entire way of submitting the documents have changed. The entire way, the whole back-end operations has changed. Still, I would like to say the technology piece in healthcare is missing. We are very, very premature in terms of using technology. Though we always say that we are using teleconsultation, like Mr. Indranil said, it's just a WhatsApp call. So how is this going to happen? Is this going to happen in a very structured way? So I was thinking about this, and there is one concept, like one is the mall concept where everybody comes together. The other concept which we are thinking of is, why should every patient come to the hospital? For example, for a simple cold, flu or a fever, if the patient walks into the hospital, in terms of getting appointment, the logistics, the traveling and the waiting time, so it occupies a lot of time. So there is something which we can do, again, for which all the private players have to collaborate together. If we can create a chain of clinics, for example, see, whenever you construct a hospital, it amounts to a lot of capex investment and a lot of infrastructure to set up. Instead of that, let's imagine, for example, you step out of the house and you see a kirana shop, you see a retail shop where you are able to pick up your SIM cards. So similar to that, if you have smaller clinics which are associated to the hospital, so he or she steps out of the home, goes to the nearest clinic, then he does a teleconsultation directly from the hospital to the clinic through a doctor, and the doctor orders certain samples to be collected. That particular clinic has those samples, the infrastructure to collect those samples. It gets collected instantly there, and there is an associated pharmacy to it. The pharmacy gets billed immediately, and the pharmacy medicines are delivered to the patient. So in that way, the patients need not go to the hospital. Instead, he goes to the nearest clinic. But how many clinics can we open? How do we partner? It could be 1,000 clinics, but 1,000 clinic is much better than opening a 250-bedded hospital or a 300-bedded hospital, which will cost 50-60 crores to set up the whole thing. So these are some of the things which we can really think about in terms of how do we bring the cost down to the patient. This will also enhance the patient experience. But I would like to reiterate again, we are very, very premature in terms of technology. In technology, we have to go a long way ahead. Thank you.
Great. Gautam, would you like to say something?
Thank you, Dr. Ashwin, and nice to hear from Indranil and Badree. So I was to say that the patient in this time has changed their expectations also a little bit. Of course, they want more information, more assurance, and they also want to talk to doctors. But the means of communication, they're all scared, so they have to have a different means of communication. But I want to just say that one of the first things that happens for the patient is like what we have done, and to just explain to people who are not from the hospital background, that earlier the patient would come to the hospital, they would be checked in, they would go to the room, and that's it, and the treatment will start. Right now, the process is that they will have to go to a triage where they will be tested, checked, where whether they are and then whether they are suspect or not, and if they are suspect, they're put in a holding area, and then the COVID test is done. And if it is a positive test, then they move to COVID ward. If it is negative, then they move to non-COVID. So suddenly, from one transaction, we have created three types of wards: suspect, positive, negative, and similarly three types of ICUs: suspect ICU, positive ICU, negative ICU. So the patients have suddenly now realized, oh, this is something different. And then what has happened is that they see all the safety measures, and they see people, security guards in PPE, and the nurses, and so there is a little bit of apprehension that what is going on. But the technology has really helped. What we have done, that we created a lot of these educational videos on, firstly, of course, talking about, what is COVID, how do you do quarantine, how do you do isolation, how do you do hand washing, and things like that, simple stuff. Then we've also done doctors talking about precautions to be taken, and then about the hospital, that what are the safety measures being taken in a hospital so that patients are reassured. And technology has been, I must say, that what COVID has done to us, and I'm in some ways thankful that we've been trying to do telemedicine for years, but it didn't happen. But now with this, it has leapfrogged. 6 years later, it's done in 2 months. And I'm sorry, not agreeing with so much with Badree and Indranil on that it's a WhatsApp call. I mean, I can tell you at least what we have done. It's a proper software where for a doctor, they can access patients' records from the hospital files on the screen. The patients can upload whatever reports they want. So they all can compare notes, and it is all live through a dedicated VPN network. And then you can write a digital prescription through the application, and the patient can download it. So it is a different experience. But I must say that initially, when it was announced, we did start with WhatsApp. But within a few days, we moved on to this technology because we were working on it. The other thing which has happened is that for this COVID care, we've realized that not all patients need hospitalization, but they have to be at home, but at home they don't know what to do. So we launched this COVID care program for home. So where we have our doctors, we have a 15-day program. So for example, in that, our doctors will talk to the patients at least 4 video consults. Our nurses will talk to the patients every day. Some nurse will take the vitals every 8 hours. So what happens is that the family of the patient and the patient are quite reassured that we are in touch with the doctor, we're in touch with the hospital. So that is also the use of technology which has allowed us now. Earlier, this was not allowed. And of course, we are also using, the technology for, analytics a little bit we have started using. And I must say for the diagnostics friends here, this RT-PCR and this antigen testing and this antibody testing, I think they are also a boon for helping in COVID care. And now patients are actually quite knowledgeable. I mean, earlier we used to say that they would always do Google and then come to hospital for a second opinion. But now they are knowledgeable, and they've heard from so many sources, from government and from other sources. So they are also open when we say, for example, when we talk about masking, so they're pretty open about it. And I can just say that the last thing patients are also asking now, and somebody mentioned here, is that they still want to talk to the doctor and see the doctor. And now sometimes we have to explain to them it is okay. Let us you do a video consult, and if the doctor feels or you feel that this is not good enough, you are welcome to come and physically consult the doctor. So which patients are happy to do that? They have an option once they are doing that. So that also, so that's just an example of some patient experiences I want to talk about. Thank you.
So, Deepak, from the pharma perspective, how has reimagination been done? Can you throw some light on this?
Yeah, so thanks, Dr. Rashmi. I think you clearly mentioned that patients with non-COVID chronic diseases have been have been facing the brunt of the continuity of care, if I can call it. That has been one of the biggest need gaps that has emerged. The continuity of care for chronic patients, because of the lockdown, because of the way hospitals had to be repurposed to accommodate COVID patient load, it has been a very stark impact. In fact, I don't think we have even started to realize the scale of impact to patients' lives who are facing non-COVID diseases. And while obviously, someone with with an ongoing dialysis and adjuvant chemotherapy, or someone on ACE inhibitors or even immunosuppressants may may have a change in their treatment plan, I think there is a much bigger impact which is actually going to be a killer on the communicable diseases front. So all the traditional killer communicable diseases like HIV, TB, and malaria have actually started resurfacing due to this entire diversion of resources towards COVID. In fact, a recent estimate by the WHO said that we are actually back by 20 years in the fight against HIV, TB, and malaria. It's a very shocking statistic. And in fact, the number of deaths estimated from these communicable diseases is far more than what COVID would end up killing in one entire year. The estimate is almost 2 million deaths because of the resurfacing and lack of diagnosis of TB, of which obviously India is the biggest contributor. There are, I think, an addition of 6 million cases of TB expected globally due to the pandemic, due to the fact that either medicines are not reaching the poor countries or those afflicted with TB, or because of lack of diagnosis, because they are not able to walk up and get their ART treatments. So I think that is going to be a big focus area. In fact, it should be for pharma and the entire healthcare ecosystem. As far as how did we handle the disruptions, I've already spoken on the manufacturing front on how did we ensure that medicines have reached all the patients and countries. But more on the portfolio and commercial front, I think most pharma companies very quickly realized the need to have what we call a COVID portfolio. And in spite of not having the in-house R&D capability or time to actually develop something which was literally evolving as we speak, right? It was like the vehicle has to keep running while your engine and wheels are getting re-engineered. I think many pharma companies, including Cipla, were very quick to activate their global network and enter into strategic partnerships to launch, first of all, to develop COVID portfolio, and if they are not having the in-house expertise, to enter into a partnership and get global rights and get quick approvals, including trials. So I think that was one of the key achievements of many pharma companies of launching critical products of COVID in record time. And from a physician and patient perspective, I think we had to quickly reimagine, as Mr. Gautam also rightly said, the patient still needs a reassuring touch with the doctor. Now it need not be physical, but it needs a quality interaction. So where the pharma companies can come in and have come in is in addressing that knowledge gap. Because remember, in these unprecedented times, doctors are first of all physically and emotionally not able to spend time with pharma reps. That is a given. Gone are the days where you will have an army of pharma reps lining up at the door of the doctor trying to promote a product. But at the same time, doctors still need to upgrade their knowledge and their scientific capability. And this is where pharma has played a good role. I think we had to quickly deploy tools to enhance the physicians or the respective specialists' virtual practice. And obviously, that needed a major shift in engagement with the physician to a completely digital content, though curated. And obviously having empathy and respect for the fact that the physician of today does not have time to go through details. He needs something very quick and very relevant to his needs. So for that, I think we deployed a variety of tools, which we will also speak of later. But essentially, there was a lot of awareness from CIPLA on the lung awareness, which is where it is actually also linked to the comorbidities of COVID. Then there was a lot of deployment of things for diabetes, which needed a continuous interaction between the physician and the patients on monitoring their symptoms, how the continuity of care is happening. uh, on the partnerships front, I think government engagement and obviously partnering with the regulatory agencies was a major focus area for us, especially in this wave of self-sufficiency where every country is trying to localize. We needed to quickly reach out to the government and regulatory and the Ministry of Health from various countries and talk about what kind of portfolio and products we can quickly get across to them. Many countries still don't have access to a lot of these effective drugs for chronic as well as acute. I'm not talking of only COVID, obviously. Uh, in terms of doctor reach, I think this has been one of the standouts. As Gautam said, telehealth and all always existed in plans and in small scale, but this has actually leapfrogged our efforts. Where now we have by default almost 70% of our doctor outreach is through digital channels. In fact, during the last 3 months, I think on the international markets, we reached out to more than 50,000 doctors through a multi-channel marketing effort. I mean, it was obviously just to educate them on what has changed since the pandemic. And obviously, pharma companies have access to all the medical journals, the latest scientific advances. So it needed a very quick turnaround and a razor sharp targeting. Also, the patient reach reached an all-time high due to those various digital campaigns. In terms of reimagining the way the sales force actually reaches out to various patients, I think that has been a major fundamental shift. Traditionally, pharma has always focused on getting maximum volume share or getting maximum doctors and patients into the fold of specific products. I think both gone are those days. The entire sales force effectiveness paradigm has shifted. It's not just the lead indicators of how many doctors you reach out to. I think there is a category of skilling for the right knowledge, right knowledge to be passed on to the doctors. In fact, the way doctors are being addressed and categorized has also changed. Instead of looking at doctor as a customer, pharma and especially our company has started looking at them as a care provider who needs our support. So, for example, why don't you focus on those whose actual market prescription volume has dropped in this pandemic? That's an indication that the doctor needs some help, because either patients are not able to reach out to him physically, or he may not have access to the latest medical updates. So that has also been redefined. I think that's it from my side at this juncture.
Great. So, what I'm hearing, and this is really good because, I had not prepared for this, but what I'm hearing again and again from all of you, from both hospital and pharma perspective, is basically personalization and customization. So, we are moving from, doing things on a large scale, and we are moving to doing things in a customized, personal way for our customers, whether it is doctors or patients. And to expand on what Deepak has just said, pharma, the service of pharma to healthcare professionals, doctors, nurses, healthcare staff is important because they are the ones who deliver care to the patients. So what we have done at CIPLA, just to expand a little bit, in the service of HCPs is, since the start of COVID, we have distributed free personal protective equipment, and we will continue to do so. We have also collaborated with the Indian Pharmaceutical Association and the API, which is the Association of Physicians of India, to distribute a guidance document on the safe reopening of doctor clinics. So this document is prepared through, the protocols that are received from organizations like the WHO and the CDC. And this has been done so that patients can reach the healthcare professionals, and healthcare professionals as well as patients need not fear exposure to COVID introduction. At CIPLA, we have also helped introduce the contactless certified clinic, and we are continuing, as Deepak said, with our doctor healthcare professional education with rich scientific content. In fact, we did over 1,200 webinars in the last 3 months. We reached out to 2.5 lakh doctors, and our net promoter score was 4.5 out of 5. And especially in the areas of respiratory, cardio, diabetes, urology, and oncology. In addition, we have engaged more than 5 lakh doctors through multi-channel platforms, omni-channel platforms, whether it is webinars, whether it is one-to-one emails, whether it is digital outreach. And this brings me to our next questions. And that next question is the solutioning outcomes that we have found. So I would now like to ask Mayurakshi, who has experience in international markets. Can you give us some information on disruption, compliance, and how did you manage compliance in international markets? And to Satya from the medical devices perspective, can you give us your view on this?
Sure.
So who would like to go first? Mayurakshi? Yeah.
Okay, let me start. So, in any crisis situation, the way to handle are three principal mottos, right? One, you do what you do best. Second, you continue to look at what is a new normal. And third is you explore improvisations. So looking at this situation, starting from in India, it is from March. In the international markets, it is from January. When this pandemic hit us, we were taken by surprise. The entire industry, the entire world was taken by surprise. We didn't know what to do. Even though this is a disease, the main thrust is for the patient to reach the providers, and the providers are the healthcare providers, the hospitals, etc. But still, there was a lot of unpreparedness in the way to handle the situation. Like, there was a significant, with COVID, not only there were no dedicated structured facilities available to treat COVID patients. And in India specifically, we had 3 months almost to learn from other, global situations. But maybe, we lived in a state of denial. We thought it might not happen to us. And, we were not prepared to handle COVID pandemic when it hit us big. And then the other bit is, of course, the OPD, the ambulatory and the elective surgery patients, where, in April, FICCI EY study estimated that revenues dropped by 50 to 70%. The overall operating, profits were, hit by between 14,000 to 20,000 crore in India, across India. So obviously, during the pandemic, people were because of the effect of the lockdown, they did not have transport to reach. And second, there was a fear of infection. So people tried to avoid, going for those elective, surgeries or those elective kind of, avoidable things, and, chose to wait. And also the interesting part is that revenue of a provider does not come from a pandemic COVID, but actually comes from this ongoing what you do best, right? Those ongoing treatment plans. So what the hospitals or the providers could have done is, rather than being reactive, doing something more proactive. And this, let me talk about the reactive part, both from COVID as well as non-COVID perspective. From the COVID, what the hospitals did way later, and as a reactive, as a directive from the government, was to convert non-COVID wards into COVID wards. Well, this could have been done as a proactive step, one. Second, when we know that, our largest revenue source, those, the ambulatories or the elective surgeries or the OPD patients are not able to reach us and we are significantly losing revenue, maybe, there was scope for increasing other alternate channels like telehealth. I hear from Deepak, from I think, also Badree, that telehealth, which was in plans always, has now taken shape, which is a surprising bit that in India, why is telehealth still in the plan stage? Why had it not come up in a big way? And this was a big opportunity for us to do innovation in a major way. The mall that Badree talks about, the marketplace concept, could have emerged. The only marketplace that I know has been successful in India is Practo, right, which provides doctors in a kind of a marketplace kind of a thing. Why not expand? Why did not more Practos come in, specifically in response to the pandemic, right? And of course, the other concept of, say, mobile clinics, right? There was, we knew that patients are not being able to reach to us, specifically not even specifically the villages, and maybe not even villages, even in the urbans, the semi-rural spaces also. Why couldn't the hospitals look at giving mobile vans, giving telemedicine, giving even tele ICU support? In fact, I read of one of the startups in the healthcare space, who I kind of engage on a different level, that they have started this tele ICU concept, and they have received funding from the institute also for the same. So these are opportunities where we could have gone in a very big way, to leverage the concept. In the global, if I look at, now comparing to the global space, say in US, etc., telemedicine is a given. US, Australia, there are two things. One, the healthcare is a very, very regulated space. There are very well-defined regulations that define how healthcare has to be provided, how patients have to be handled, how the insurance payment has to be structured, and more importantly, on privacy and security of the patient data, right? With all of that, telehealth was promoted, and telehealth started right from the beginning, in those international markets. Yes, talking about improvisations, there are three tiers, right? There is a patient, there is a provider, and there is a payer. Patient cannot improvise too much. The payer, that is insurances, cannot again improvise too much, but there was a lot of improvisations possible in the payer space, that is the hospitals and the doctors, and they did innovate. And the regulator in the international markets, for example, in the US market, there is the HHS, the Health and Human Services, who are the regulators in the healthcare space. They promulgate one of the very significant regulations called HIPAA, Health Insurance Portability and Accountability Act, which is a very, very stringent act on privacy and security of patient data, because to them it is a very, very critical thing to protect the privacy of patient clinical data, patient health records. So HHS came up with regulations not for telemedicine. It was already there with regulations giving how in the pandemic space the regulation can be relaxed a bit for telemedicine. For example, in an otherwise situation, the patient health record cannot be handled, cannot be stored unless certain protocols are followed. But in this pandemic situation, the HHS gave some relaxation that if since you are depending upon teleconferencing, like for example, you might use a Zoom, right, to interact and connect with a client, or you might use a simple video through your mobile phone, but through that you are actually collecting the patient data, you are getting the patient records. This gets formulated into the patient's electronic health records, or the EHR, and the electronic medical records, or the EMR, right? But because of the pandemic, they understood that the records, the security protocols that are otherwise to be there could not be there, so they gave some relaxation on the way of handling. So in the international space, these are the way that the regulations have also responded. In India, unfortunately, again, we are yet to, I won't say do not, we are yet to have a strong regulation around data privacy, not only on the healthcare space, but in general. We do not really have a big structured regulation for healthcare space. The JCT, which is what some of the leading hospitals follow, is again international regulation, and it is not an easy standard to follow. So hopefully, the government should come up with some regulatory support to guide, and the hospitals, the providers should look at how they should improvise to remain agile, to improve support. And maybe I'll stop here and maybe talk more about what kind of other innovations the international market is doing vis-a-vis in India.
So I think with the COVID pandemic, I think the government of India now allows telemedicine as a consulting platform. And I think it's also allowed to pay a doctor for a consultation on a telemedicine platform. That is my, information. But if any of you have further information, let me know. Satya, would you like to say something from the perspective of the device industry?
Yeah, sure, Dr. Rashmi. As the saying goes, the change is inevitable. At present, the COVID times is providing the thrust required to bring the change in the whole world and to accept the new normalcy to lead the usual life. And definitely the medical devices being in the same ecosystem, and it's deeply impacted because many of those cases are also elective ones. But then it's also providing new opportunities and certainly opening up the new ways of doing the business. So from a medical device industry perspective, specifically where I come from, the cardiac implantables, the challenges are slightly different. The patients, if you see, the final treatment is always a real time and not virtual or by the tele-prescription. Patient has to undergo the procedures in the cath lab or OTs depending on the mode of treatment. So cardiac OTs or the cath labs are high sensitive areas, and a sterile environment is maintained always, irrespective of the COVID times. So pre and post each case, there are a set of protocols and the fumigation process followed for the safety of the patient as well as the operators. Almost all the hospitals dealing with these specialties mainly maintain the specific cardiac OTs and cardiac ICUs, etc., and beds, etc. So the chance of contagious infection is largely prevented. And if you see the awareness of this now, and the acceptance of the new norms, though the procedures, the number of procedures have significantly come down initially, now it is like most slightly coming back and gradually going up. So when the challenge comes to reducing the number of physical visit to the hospital, especially the pre and post procedure, for that the telehealth and the digital health has been very helpful. Largely, these procedures are decided based on some imaging modality, be it an echo, MRI, ECG, and CT scan. These initial screening reports are to be shared electronically, and the procedure date and modalities are fixed well before the case itself, except in the case of an emergency. So another one more area like which we look at, where the device industry looks at, is some of these new procedures. There are novel procedures which comes in, and the SOPs and the protocols suggest and insist these procedures are to be done under an experienced and certified proctor, ensuring the patient safety. Earlier, these proctors used to travel long and far and to support the cases. Now the medical devices are adopting teleproctoring as an alternative for doing these cases, where the proctor could be connected from anywhere of the world, but connected through the video conferencing throughout the procedure, guiding the operator. Recently, we did like a multiple teleproctoring from Europe to Malaysia and from India to Nigeria and other African regions. Again, here the safety is ensured by multiple planning calls well before the procedure, and roles and steps of each person involved are defined and discussed, thus to ensure the procedure goes seamless. We also have been using technology such as 3D printing of the models, anatomy, and making the tailor-made devices, specifically helping to treat the rare cases and anatomies. Now, as I said earlier, one of the key areas the device industry partner is for upgrading the skills and improving the therapy accessibility. In fact, we at LifeTech India are one of the early adopters to start the webinars based on the concept of sharing the learning as early as in March. It's March end. Started conducting masterclass sessions, connecting experts from around the world with Indian physicians, enabling a platform to share their experiences. And program was very well attended and deeply appreciated. And ever since, there's been a huge amount of late learning happening with many companies using the technology at this difficult time. So in terms of improving the accessibility and ensuring the patient safety, we've been coordinating to do multiple workshop and hands-on workshop in remote villages. Now, where the expert physician travel to these remote places and do cases in the local hospitals. So thus avoiding the need for the patient or the families to travel far to a bigger city or the hospital. And as an extended service, we have just started collaborating with a couple of technology companies, providing the latest technology that can help to increase the safe reusage of the disposable like mask and PPEs, which can eventually reduce the environmental impact, at least to some extent. Thus, as never before, I believe the technology is intensifying its impact on the healthcare delivery and will definitely become a huge part of the healthcare sector.
Great. So thanks, Satya. Thanks, Mayurakshi. And I think I will now, move a little to home healthcare. So can the panelists give some examples of how the environment for home healthcare has changed? I think everybody has talked a little bit about it. Gautam has talked about it. Indranil has talked about it. What are the additional initiatives that your organizations have taken for home healthcare in the current environment? And Gaurav, what is the availability of health insurance for such home healthcare initiatives? And can you also speak a little about your patient support programs that you deliver through the home healthcare services? So maybe we can start with Gaurav, and then maybe if Gautam can talk a little bit about how Hinduja Hospital has been providing home healthcare services, and Indranil can talk a little about home healthcare through in the area of diagnosis.
Yeah, thank you, Dr. Hegde. I think the biggest thing after telehealth, what has happened is home healthcare during the COVID times, where people always knew that there was something called home healthcare, but when they didn't want to go into the hospitals, it became an ideal solution or ideal alternate to be treated at home. I think the biggest thing which has happened is acceptance to a phygital model. Before COVID, it was not even thought of that if you don't have a physical person, whether it's a nurse or a physiotherapist or even a doctor going at home, as somebody mentioned, or a nursing assistant, it doesn't account for home care. And it was something good to have as a post-discharge service. Whereas now it is more of a phygital, where home isolation programs, as Gautam was mentioning, has become a norm. It has been certified by the government. We are now at HCH working in a tender with Delhi government, where thousands of patients are being managed on home isolation programs at home. So I think the biggest thing which has happened is the acceptance of this. The second is the phygital model. I think each one of the panelists spoke about home healthcare, which gives it a lot of credence of what we have been doing over the last 8 years. I think another thing which has happened here is government. I think most of the governments, we are working with government of Delhi, we are working with government of Karnataka, and there are many other governments which are also promoting triaging and management of COVID patients at home. So I think this is something which has drastically changed. As COVID happened, as Mayurakshi said, we were also taken by a surprise. our biggest endeavor was to how to cater to our existing patients in lockdown, how to get people at homes. And we have been running ICUs at home for 4+ years, where we have been running these tele ICUs across the length and breadth of the country. So for us, that because we had this regulated environment, we were already using things which were given in the telehealth guidelines by the Board of Governors of MCI, which you rightly mentioned, which government approved in the lockdown phase 1. Because we were always using it, that became our, I think, a USP to manage patients at home are existing. But then what we started seeing was that there were a lot of queries around COVID. Before COVID, if somebody would get fever, you would pop up a crocin or something and you'll be fine. But now you wanted to talk to somebody. You had so many questions. There was fear psychosis. What will happen to me? How do I isolate myself? What do I do with my parents who are old, with my children? So we launched a helpline, and then this helpline got adopted by, even we did it for BMC in Mumbai, for the citizens of Bhopal, Indore, Pune, and many corporates adopted it. And the next thing which came out of is, I want to speak to a doctor. And because we were already practicing telemedicine and it saw a huge surge, we had around the clock doctors, whether it was GPs, whether it was specialists, or even ICU teams managing tele ICUs, consulting patients who could be managed at home. The third thing which came is, doctor has given a prescription. How do you fulfill that prescription? And again, telemedicine moved away, just not being restricted to doctors, but to going to tele-rehabilitation by physiotherapists, diet counseling. And one thing which emerged very, very strongly in these times was psychological counseling, right? So psychological counseling, people were so anxious that they opted a lot for this confidential telemedicine, psychological counseling also. Now, the next thing which came up was home sample collection, because doctors prescribe a test. That was another initiative which we ran across so many cities and did thousands of home sample collections for RT-PCR and now antibody also. But I think the biggest advantage in COVID times which we were able to give to people was on home isolation program. People wanted to be at home initially, as the government mandated that they had to go into COVID care centers, which were only government mandated. People were not coming out. There was a lot of stigmatization. They felt safe in their own confines, but they didn't know what to do. And that's where, through telemedicine, through a lot of AV tools, as Gautam mentioned, a lot of educational videos, how do you isolate, how do you manage your laundry, your crockery, your caregiver, what medications, and round-the-clock helpline to just answer your queries, and the doctor availability to talk to you. So that thing again got adopted at a very big level. We made it as per the 10th of May Government of India guidelines. And as I told you, now we are running the largest programs for the government on home isolation. We are also the back end of Fortis Healthcare across country and many other hospitals, where we are the back end of managing home isolation programs. So that is all what happened on the COVID side. One thing which we all are doing, as you said, you did 1,200 webinars. We started doing webinars, which we started with our own staff, which we wanted to motivate and treat COVID patients at home. It became a big thing, and we were able to do around 50 plus webinars with top doctors and administrators from the country on various specialities, which also picked up a lot of awareness things to empower our audience. So these are the things under COVID. But another drastic thing which happened was on the non-COVID thing. People were not able to go to the hospitals. Things like infusions, oncology, chemotherapies, dialysis. In Mumbai itself, I know there were so many dialysis centers which got closed down because the hospitals got infected. They became the hotspots. And then there was a surge in all these things where home healthcare became an alternate to the hospital. And that's where we saw a lot of surge into that also. And coming to I'll talk about the patient support program maybe later on. With CIPLA itself, I think we did a lot of promotion to the oncologist on getting chemotherapies at home, and we were able to do quite a few in the major metros and semi-metros of the country. So that was there on the COVID and non-COVID new things which happened during the last 3-4 months. The interesting things which happened is that IRDA mandated all insurance, whether it is healthcare insurance, whether it is GIC, whether it is life insurance, to include home healthcare into their COVID standard policy. A COVID standard policy which covered telemedicine, which covered home isolation program, which covered nursing at home, which even covered medication, oxygen, depending upon what is your coverage and what kind of policy is. But in some sort and everything, there was a standard policy which was rolled out from 10th of July onwards, which mandated every insurance to cover home healthcare. That led to another surge of people opting for it, because now the payer thing was also getting sorted. So with government and insurance supporting it, I think there was a lot of acceptability, credibility. But the next thing was, how do you empanel somebody who can provide quality care? So 3 years back, we instituted accreditation standards from home healthcare in the country, and this was the time, right, when we got it approved by International Society of Quality Assurance also. And that's where we made these entry level standards where many new players could also empanel. And today itself, 4 organizations are accredited with the home healthcare standards, which make it a quality benchmark like NABH for the insurance or the government to adopt quality players to give the services. On patient support programs, Dr. Hegde, I would like to share with you that we are the largest providers of patient support programs, and we work with 40 top MNCs, including Cipla also, where we follow the patient journey with the sole objective of having better patient outcomes and managing them in the confines of their own home. So right from screening, diagnostics, to counseling, to prescription initiation, to fulfillment of direct-to-patient medication needs, to home infusions, to even collecting clinical outcomes and giving real-world evidence to the doctor and in anonymous format back to the pharma itself, that how the drug is behaving, is all what we do with more than 3 lakh patients per month. And what we saw the role of these patient support programs was that when people were not able to go to the OPDs, or the specialty drugs started getting replaced by more non-specialty drugs, we were able to retain patients on specialty drugs just because of the programs, because there were counselors, nurses, dietitians, people who were constantly in touch through telemedicine with these people. And we had this whole delivery mechanism sorted at 400 locations in the country. Even during the lockdown, we were able to retain patients on medication for the specialty drugs at least. Yes, definitely the new prescription went away, but the real essence of patient support programs came during the COVID times also. So that's my view. And as Gautam said, home healthcare now has become a very, very vital, essential parameter for continuum of care, whether it is pre-admission, whether it is an alternate to the hospital, or whether it is post-admission. When people don't want to go to the hospitals, people want quality care at home, or people want to go to the hospitals only for the sake of what can be done only in the hospitals.
Great. Gautam, you touched upon home healthcare services provided by Hinduja Hospital, but do you want to again add to what you said before? Would you like to add something?
Okay, just a couple of points. I think Gaurav has described in detail, and I think it's very, very appropriate whatever he has said. So I just wanted to say that since we started this care at home program in 2006 or so, and since then the focus had been on collecting lab samples from home. So that was the first focus, and sending some nurses for changing the dressings and taking care of like people who are post hospitalization. They need some change at home, so some minor stuff, but that was going on. But now in this COVID time, it has been brought to focus, and everything is now, people are open to this. And I talked about the COVID care package which we have launched, and I'm also happy to say that and I think Gaurav just touched upon it, but I'm going to talk about that as part of our package, we also included one counseling with the psychologist, clinical psychologist, because so now that is also opened up another stream, that people are open to doing some counseling sessions from home. Earlier they would come to a hospital and so on. The other thing part of the package was a discussion with a dietitian. So that also now has opened one more. So now we have, so what we have through this home care package is psychologist consulting, dietitian consulting, nurses care, doctor consulting. Of course, phlebotomists still have to visit and take the samples. We also introduced online physiotherapy. So earlier physiotherapists would go home, but now physiotherapist is online. So all that is there. And I have to just say this for, I think Mayurakshi mentioned this, that why was this part of the plan? Why was it not implemented? So I think I just want to say that earlier the government rules did not allow us to do any teleconsultation, and e-prescriptions were not allowed. Only when the COVID crisis came, they relaxed the MCI relaxed the rules, and doctors were allowed to consult. So the plans were always ready, but this got implemented because of that. And the second thing is, in terms of future, I think my view is, and I'm sure many of us on this panel will say, I think home care is here to stay, and lot of healthcare delivery will be through digital channels, and I'm counting this as digital channels. So, and I think this is probably one of the answers, not the only answer, to India's big problem of shortage of beds and hospitals. Because now suddenly this gives us an opportunity to move hospital beyond the physical infrastructure. I mean, I can tie up with Gaurav's company, and we can reach many, many more patients across the country. And I mean, I've had examples of people who have dialed in, who have taken a package from Darbhanga in Bihar, people from Bangalore, somebody from the US called and said, I want to take this package. So suddenly the hospital is not confined to my physical building, it is just everywhere. So I think that's a great opportunity which is there for the patients of the country. I'm going to
Indranil,
stop.
do you want to say anything from the diagnostic perspective?
I think most of the points for home health care have been covered by Dr. Gaurav as well as Mr. Khanna. From the diagnostic perspective, I would like to highlight only one thing, something which was never considered as a diagnostic industry that can be practiced in this country. See, we all know there are certain point of care tests, like many of us use AccuCheck or some of those other devices to check our daily blood pressure, lipids, and all. So both the clinicians as well as the diagnostic fraternity as well as many people had a lot of reservation given the varied temperature and humidity conditions in our country about the reliability of results of those point of care tests. And with the COVID antigen test which was launched. And I know now some of the US companies, Roche, is coming up with a much more reliable biosensored kit. So that is one what is coming up. Fortunately, unfortunately, those sample cannot be transported. You have to take the nasopharyngeal swab, put it in the kit, and within 15 minutes, it changes its color to tell you whether it is positive or negative. The ICMR guidelines also says if it is positive, the patient can be stamped as a COVID positive. But if it is negative and the patient is having influenza-like symptoms, then the patient has to be confirmed by RT-PCR. So the essence of the thing is we are probably shifting to point of care test in diagnostics, which is going to give us confirmed, reliable result. We are probably just seeing the dawn of that. If that happens, it is going to revolutionize the diagnostic industry immensely. There is going to be a lot of advantage, and home healthcare in that is going to really benefit immensely. That's the only point I will make. Thank you.
Yeah. So I think, to say a little from the pharma industry perspective, I think health technology and health technology assessments of patient health, health point of care devices, and we have now apparently point of care ECG, we have point of care peak expiratory flow meters, and other point of care devices for measuring thyroid function, for measuring hemoglobin. And I think more and more will be available. I read something yesterday which said an Alzheimer's disease diagnostic test is available, which can predict when the patient will have, or if the patient will have Alzheimer's 20 years from now. So all these things will are definitely changing the landscape. I think on the one side we're also talking about robotics and how robotics will help read X-rays, read CT scans. But I think, and also how it will probably take away healthcare jobs. But I don't think that's true. I think the healthcare jobs will just move maybe from doing routine work to the delivery, as Gautam said. It will be the delivery of medicine or delivery of healthcare which will become important, which will be customized, which will be personalized, and which will, maybe have a change in the way it is delivered. So I think there is still hope for all of us. Um, So we've talked about the reach to healthcare providers, the access to medicines. The healthcare providers could be hospitals, doctors, pharmacists, physiotherapists, psychologists, as Gautam mentioned, and path labs. And this is important to all patients and patients especially with chronic disease. At CIPLA, we made available a free teleconsultation platform for doctors. We had three provider companies, and they gave end-to-end solutions to the patients through the doctors, of course. Access to a doctor consult, access to diagnosis, access to medicines, as well as follow-up allied services like dietitian, physiotherapist, and psychologist available. Similarly, we introduced the first digital patient education platform. We have these breathe free educators, and they are deployed for respiratory patients. They teach patients with respiratory disease how to use the inhalers properly, because it is found that 40% of patients who have asthma or COPD don't use their inhalers properly, leading to either disease progression or leading to acute exacerbations requiring hospital admission. So we now deployed these digital patient educators, the breathe free educators online, and we also plan to introduce a digital module on rehabilitation exercises. And altogether in this quarter, beginning July, we are poised to cover over 1.7 lakh COVID patients through our COVID medicines. So all of you have talked of the role of digital, the role of telehealth, and what have been the regulations and how they have come into play, and how we are now able to roll out digital and telehealth to our patients and in our businesses. So how do we ensure that such platforms are compliant from the perspective of patient confidentiality, data security, and from hacking? There is also a question from Manoj, which talks about digital transformation in R&D. So if Satya and Mayurakshi, you can take these questions.
Okay. To quote John Noster, a digital health philosopher, he states, like never before, we are seeing an interesting convergence in the technology, medicine, social issues, and human progress. So, along with the rise of artificial intelligence or the machine learning, one area which has gathered momentum and remain as a major challenge in the is the data security and the confidentiality. Let's understand the data collection by the system to study and develop the algorithms has been there for quite some time, right from the Google, almost all the platforms we interact, collates the user data to develop the algorithms and for probable future commercialization. What we need to see is that if the sensitive personal data are being shared or hacked, many leading hospitals, as Mr. Gautam was telling, they use their own dedicated platforms, ensuring the data are protected. And if you look at like the telemedicine, telehealth, the leaders in this segment are like Protea, Pacto, 1mg, and MedLife. We've seen a continuous evolution of safety measures adopted by these developers of these platforms to enhance the safety profiles. And in the wake of COVID-19, as early as in March 2020, when the social distancing was mandated, the government of India has come up with a new set of guidelines, as Mr. Gautam was telling, to make use of the telemedicine as a legal practice in India. This is rolled out by the Ministry of Health and Welfare along with the Niti Aayog, with a set of guidelines for the physicians, service enablers, and the healthcare providers. This is quite a well-defined guideline defining the appropriateness of the telemedicine, telehealth in terms of setting the standard of services, patient management, education, and even the data management. And in terms of the medical ethics, data privacy, and confidentiality, they have prescribed a set of 7 rules to be specific as guideline for the technology platform enablers to follow, and specifies very, very stringent rule for the non-adherence and the non-compliance in this. So I think largely the awareness among the common people have increased, forcing the system to adopt and enhance the safety measures. And I'm pretty sure this is going to get much better as we go forward.
You want to say something, Mayurakshi?
Yeah, I'll just, thank you, Satya. So I'll just add on to the point that Satya just mentioned, and, just expand from the, the regulations that the government has given, the, Department of Health had given. Now, data, as they say, is a new oil. And in some countries like US, Germany, Australia, etc., patient health data had been, as important or even more important than financial data in terms of requirements of security, privacy, confidentiality, and all. Right? This part is still missing, and missing in a big way in India. If you see, the India government guidelines are just that, guidelines. The moment you do not have a strict enforceability, which you cannot put up in a court of law, the regulation does not become as compiling, which is also the case for the data privacy law that the government of India is still not yet finalized, because people have some inhibitions, some questions around that. Now, looking at the healthcare space, and the way the healthcare space has evolved over this last 3-4 months, and I'm talking more of the innovations that has happened in the international markets. Like there has been, as you also mentioned, Dr. Rashmi, that we cannot move away from the provider of service. We have to look at how we can improvise on that, right? So for example, we, like you said, CIPLA has developed a platform, right? So there are some hospitals like Apollo also has a platform. I used to be a consultant with Apollo ages back, more than a decade back, and I remember they had a platform. CIPLA has developed a platform. So there are platforms being developed as an individual organization level. What is required is, for this to operate in a country level, is the concept of interoperability, right? Which means that the data that your platform collects for a patient, the way it translates into a EMR, electronic medical record, what kind of codification norms, what kind of digitization norms it should have, what should be those common parameters, so that a record created in one hospital or one pharmaceutical can be read seamlessly into another one. This is the concept of interoperability. And second is that, if there is a record of one patient in one hospital, can it be transferred in a electronic means? Do we have the channels, the communication modes, the security protocols defined, so that that data can be read at another provider or another pharmacy level? Those are the places where India has to come up with regulations, whereas say a more evolved healthcare space country like a US or Australia have already very well defined guidelines around that. Now, the pandemic has led to a lot of, new attacks, as we know, and that has mostly come not in the healthcare space as much, but into the overall space on the, because people have moved to work from home. So, the attack of phishing, for example, has seen a 600% rise. Though we have not seen, too many data phishing or attacks on the healthcare space, one reason could be that in the healthcare space we still do not have too much of digitized records, right? But once we progress on that, we need to have very strict norms to protect the confidentiality of data, who can have access, how data can be moved from one system to another, what kind of controls, processes, security parameters to be built at each system level, what rights has to be given to the patient, and what rights to be given to the providers, what kind of identity norms that we have to understand that the person who's trying to access the system is who he claims himself or herself to be, the identity norms. Then we are like in the US space, they have understood that to improvise, we need to look at digitization in a different way. The jobs are not going to go, but people are going to remove the routine, mundane jobs, like for example, regular billing. Right? All you have to do is look at the invoice, prepare the bill. Look at the invoice, prepare a bill. This in the current scenario, these are outsourced, to a lot of India and Philippines and all those countries. They are now demanding that with the pressure on their profitability, they are demanding that let that gets automated, right? So the moment you bring automation, we, like for example, my company is designing platforms around robotic process automation, or RPA, and also NLP, natural language processing, to automated coding, where we can read 100 patient charts. And I'm talking of the US scenario where the charts are already digitized. So I can read, the machine can go ahead, read 100 patient charts, look at symptoms, specific symptoms of diagnostics, and then come up with one report, all in a matter of seconds, to look at indicators of diagnostics, which can then again be looked at a medical, actually a doctor, a certified medical professional, to do a better diagnostic and analysis. So these are all the next level of digitization. But all of this, the moment you put these advanced technologies, come with the risk of protection. Second, lot of these data is going to be on the cloud. Then the entire paradigm of cloud security, interoperability, country and cross territory movement of data come to be into place. So yes, while the possibilities are huge in terms of digitization, automation, and all, the risks, if I might say, of data security, data compromise are also really huge, and we require very stringent guidelines, very stringent education, both to the patients as well as to the doctors, to do this. I remember, on the last bit, I'll say that when we were doing the consulting with Apollo decades back, a decade back, I remember the biggest challenge that happened was educating the doctors to do this bit, because if I look at from their mindset, the doctors are here to do life-saving activities. You ask them to punch in records, they say, hey, I cannot waste my time into punching records or looking at whether the documentation has been correct, or whether I have been able to do that. So there is the right balance to be made, the right systems to be put. There's a lot of education sessions that we used to run for them.
Yeah, thank you, Mayurakshi. So Mayurakshi has actually covered also what is going to be our next question, which is, we are in the last 13 minutes of our session today. So we have, covered, Mayurakshi has covered from the government perspectives, but I would just like to ask Gautam, maybe Indranil and Deepak, if you all want to say anything about the government, and that is also part of a question that has come to us, about what is the support that we expect from the government, from the regulations in optimization of healthcare operations beyond this pandemic. So what policy, regulatory changes do we expect? Would we like? Okay, so if y'all can very quickly answer it. So somebody also has asked this in a question. So yeah, Gautam.
Yeah. So I was going to say that somebody asked that question. So, from the government perspective, my only request to the government is that, of course, government is concerned when the population of the country talks about pricing and says that everything is high priced. But what they miss out is that the cost of treatment in India is, maybe 10% of what is globally available, with global equipment, global protocols, global treatment possible. So everything is very, very cheap. So the issue is not about the pricing, issue is about the affordability and the ability to pay. So currently, if the population of the country has a very low level of insurance, they cannot be expected to pay a hospital for a regular bill. So they will always say it's expensive. It's like I have 10 rupees in my pocket and the bill is 20 rupees. I think it's expensive, but if I have 100 rupees, 20 rupees is nothing. So it is a question of adequate insurance. So my request to government is to ensure and maybe make it mandatory for everybody to have a health insurance. I mean, if I have to make a insurance for a motor car or a motorcycle, which is mandatory, why can't it be mandatory for a human body? I think that is something which is my request to the government. Second thing is that sometimes it is not possible to do the infrastructure changes. The hospitals have been designed to be for a non-COVID. Just a minute, I'll take that non-COVID, the air conditioning is positive pressure, that no infection should come in. While for COVID, it has to be negative pressure that no infection should go out. So the infrastructure requires changing. So it is not so easy to just say from tomorrow you will admit all COVID patients. It's not easy. So there has to be properly thought out that what can be converted, what cannot be converted, keeping in mind the safety of the patient, safety of the staff, and of course safety of the non-COVID patients, because they will still need the earlier model of the hospital, which is a positive pressure. And the last thing is, if we can have a joint effort together, and I'm happy to say that the private healthcare providers have always been supporting the government and will completely support the government in this fight against the pandemic, that we can continue to have private awareness programs, more collaboration, and if the government can help with better taxation and GST and some other financing incentives, because in this pandemic, what has been clearly shown out that the hospitals are bleeding like nobody's business. And many of the hospitals are incurring huge losses, they have huge debts, and the answer given to me is that all the other sectors are bleeding. I understand, but all the other sectors are going to get some help from the government in some package. Hospitals are not going to get. And if hospitals are bleeding and if they close down, it will be a big disaster for the citizens of the country, because if there's nobody to provide healthcare, what are we going to do? So think about helping the hospitals, I mean, bring them out of the ICU, if I can use the word. So that's all I will stop.
Yeah, Deepak, you want to say something?
Yeah, I think from a pharma perspective, while it's obviously, the public health officials have been spending the right amount of energy and resources on making treatments and healthcare infrastructure available. But I would again focus on the real impact which is going to be seen in a post-COVID situation, where more of the chronic patients are going to develop COVID and the two populations will merge. I think in this context, not just the Indian government, but I would speak on behalf of all international markets also, governments need to make regulatory pathways very simple and not have unnecessary layers of approvals. Obviously, without compromising on quality, they need to ensure that the right products are approved in the right timelines, and obviously while we are looking at prevention to this disease, and vaccines is rightfully having all the attention, we need to have more of voluntary and compulsory licenses, and that's where the Indian government has actually been a role model, where we have introduced in the past compulsory licenses to make affordable treatments for ARV and oncology now. So I think quick regulatory pathways, quick approvals, and obviously do not compromise on investing in non-COVID diseases. I think there's already a lot of resources being used for COVID. We cannot ignore trials and investments in other products. So those are the three asks from my side.
Yes. So I would also agree with Gautam that, we have to increase the insurance, that is, make mandatory and increase the insurance for healthcare, because today, if you see, I think health insurance is, the penetration is very low. And even if you see people who are health insured, significantly health insured, I would say that the amount they pay for health insurance is probably the same as what they pay for their car insurance. And you cannot, the human body is not replaceable, no part in the human body is replaceable. So obviously one has to be insured for health at a much higher level. Anybody else wants to take this question? Yes, Indranil.
Yeah, I would just, everyone spoke about insurance. Let me just make a few quick highlights. 70% of our healthcare decision depends on a diagnostic test. But do we know that out of our total spend in our country, 5% of the total healthcare spend is only diagnostics? And the reason is most of it is not insurance covered. Unless you diagnose the problem, how are you going to treat it? So government has to play a major role. I'm not covering that. That's already covered. I will only highlight two things here. One is the need for wellness and the preventive check. We know in the COVID era, if someone's immunity is better, they can fight the disease, they can combat the disease better. So there's a need for a mass awareness program from the government, which will educate every citizen on the need for a preventive health checkup. If you can go, Mr. Khanna was talking and giving an analogy of a car. If you can get your car serviced every year, why can't you get your health checkup done every year? What is the problem? No, as you rightly said, at the end of the day, no part of the human body is replaceable. What is the harm in spending some 4, 5,000 or even 3,000 bucks in getting your preventive health check done? So government needs to look at that, and various PPP models can be worked out for that. The other only point I will highlight, unfortunately, in our country, the diagnostic space specifically is not properly regulated. Pharma is highly regulated, but not the diagnostic space. Due to COVID, NABL has come to the forefront. There's a specific need for the government of India to define this and standardize this. This is a highly fragmented, decomposed market. The need at this time is to provide the same standard of quality across the country, and the government has a major role to play in that. Thank you.
We can very quickly move to the questions. So Manoj has said that, will this crisis bring an opportunity and will it open more conversations about data sharing across the industry? So I think that has been answered, that yes, there is a need for data sharing and, interoperability and interconvertibility across territories also of data. The second question from Manoj is, again, how pharma companies are accelerating digital transformation in R&D. So, of course, in R&D, we now have something known as in silico clinical trials, which is basically modeling of diseases and modeling of the use of drugs. And I think this actually helps us to reduce the healthcare costs and also to reduce the amount of time taken to achieve. And I think some of these models have been put in place for the development of vaccines, which is why we are talking about the availability of vaccine by the end of this year for COVID or even early next year. Usually such vaccines would be available after 5 or 6 years of development. Also, the medicines that are being available for COVID right now, remdesivir and favipiravir, they have come through a model known as repurposing model, where you have repurposed existing drugs and therefore you are able to get this quickly. Does anyone else want to answer this question on accelerating digital in R&D? I don't think so. Okay, lots of compliments for everybody who has participated in the discussion, to the panelists. One question to Gautam saying, what is done to ensure non-COVID-19 patients get their regular medicines and treatment? So I think, do you want to say anything else, or Emma has asked this question, or I think you've already mentioned it, but
I think I've mentioned that. I'm just going to say for Emma that there is a separate building for non-COVID patients, and before the patients are entered, they are triaged, and they are, depending on the diagnosis and the test. If they are COVID, they go to COVID. Otherwise, they go to non-COVID. Our operation theaters are functional. ICUs are functional. They are all separate. Doctors are separate. So it's like a regular operation for regular procedures. For non-COVID, they are completely on. Medicine supply is there, so there's no constraint. There's no. The only precaution is that we use additional PPE for all the staff, depending on the level of risk assessment in different areas, whether it's ICU wards or common areas. So that's all. Otherwise, everything is fine.
Okay. One other question by Walmi is that what is the assistance that healthcare industry requires through regulatory changes? I think everybody has spoken on that, from the hospital, pharma, as well as diagnostic perspective. Manjeet has a question on saying that PPP or public-private partnership is the way ahead. The only way during such a pandemic, no one can work in isolation. Does anybody want to say anything about it?
The only point, Dr. Rashmi, I want to say is, yes, they are the right way, but the government needs to ensure that the payments are given on time. If the money is not circling, then the entire business model goes down. That's the only point.
Aneet has said patient support model is running in the non-COVID scenario, also for the specialty segment. It's possible due to direct contact with the patient, same as insulin newer version. So what he's probably trying to say is that it's a newer version of what was available previously. And he also goes on to say patient education, telemedicine is all the need of the hour. Then Rafiq mentions the way, also Aneet mentions that, even the mobile phone app can be used as a point of care device. We agree with you, Aneet. Rafiq mentions the way corporate employees' annual health checkup services delivered has now been impacted, but due to COVID, from the diagnostic companies, what will be the way forward strategy? So does anyone want to take it? Annual health checkup services.
So I mean, we can look at that in doing a home care service, like blood samples can be collected at home. Beyond that, I would request Mr. Khanna. I think he wanted to say something.
Yeah.
So I was going to say that when this pandemic started, we actually closed down our health check. But now we are in the process of evaluating that how we open it with all the protocols, because health check is blood work plus other equipment which is required, which will be installed in our hospital. So it is a question of time. With adequate protocols and social distancing, it will be done. So it's a question of a couple of months. So for this gentleman, I think it is going to happen. People will just catch up and it will be normal again.
Yeah. So Aneet is also asking, what is the average cost of a whole body checkup? Do you want to answer? I think it depends.
It depends. It depends largely. It can start somewhere from $1,000 or even lower than that. It can even go up to $10,000. It depends what type of tests and what are the modalities you are including in that.
Okay, great. So now the last question, which is a very interesting question, and I'll want all of you to pitch in. It's from Daniel, which says, how does one ensure that risk assessments, especially in the current COVID situation, are not just a box ticking exercise? How does one ensure that risk assessments, especially in the current COVID situation, are not just a box ticking exercise?
Okay, shall I go first? Okay. There are two aspects of a risk assessment or a risk management, right? One is in a normal situation and one is in a crisis situation, right? So if, in a normal situation, you take time, you look at historical data, right? And then, you look at, current your infrastructure, your setup, and then you try to do some prediction to assess the risks. In a crisis situation, you do not have that luxury, right? One, it has never happened before. Second, you are running against time, so you have to take decisions on the go. So I was watching a webinar by one of the largest US CEO of the largest healthcare hospital, and he said that they used to do meetings every day morning to manage the risks, and the data used to be the data of previous day, right? So every single day they did that, and they did the very quick analytics to predict that what were the diagnostic results, what were those specific situations, what kind of comorbidities can be relatable to the deaths or the movement of the patients from one stage to another, and they used to manage in terms of also the capacity, the number of hits that can happen on the devices, the hospital beds and all that. So in a crisis, you have to be on the go, and yes, it can never be a tick on the box. On the Indian context, I can say that there were very good steps taken to contain in Dharavi. hope that we could have done the
Yes.
same thing across Mumbai.
Yes, great, great. Anybody else wants to add? So, Gautam, from a hospital perspective, we are beyond time actually, but nonetheless, I think it's
Just
a very important question.
Yeah, I
Yeah,
just so Daniel has said. So firstly, I should say, Daniel, thank you for asking that question, because I have to say this, that the main point to avoid this checking the box is that the top leadership has to be committed to it, and committed in not in sense of checking the boxes, but actually getting into the trenches and going into details and asking questions. So, for example, now like Mayurakshi talked about, now we did this from the day it started in Mumbai, 12th of March. We did two meetings. So like a war room meeting with non-clinical people for almost 2 hours, and with for an hour and a half and maybe 2 hours with clinical people every day, and it continues till date. Now the only leeway is that we don't do it on Sundays. But earlier we were doing, there was no Sunday, no holiday, nothing. So there exactly it was this, that find out the information of the previous day, see what happened in the night, take decisions in the morning, and just move on, because we were also learning on the fly. So that is one. But having said that, we have done a proper, and we made a proper risk assessment document, at least in the hospital area, that which is green, orange, red, so on. Huh? And we have been updating it regularly. And the key to this, Daniel, is somebody to ask questions. For example, I would ask question, go in detail. So the moment somebody asks questions and it is being reviewed on a regular basis, this activity of checking the box doesn't happen. It is actually being implemented. And you see the implementation. You go down to the areas and say, by the way, this was a red zone. Why are you following the orange zone thing? Then suddenly all the wheels start turning. And it's a question of time, but after a while, it just becomes habit and norm for everybody.
Yeah. Okay, so great. I agree completely with you, Gautam, and that's what we've been doing also from the pharma perspective, getting all the data on the risk, brainstorming, coming up with ideas for a management plan, piloting things. So that's another of the things that we did, and then we put in place a risk management plan, hard analytics of the hard data, uh, in the RMP, in the risk management plan, and finally customer feedback. So the hard data, analytics of the hard data will tell you if you are going wrong, and the second thing that will tell you if you're going wrong and you're just doing a tick box exercise is by asking your customers. I think that's why we had the net promoter score when we did all these doctor meetings. So thank you everybody for a most interesting panel discussion. My dear colleagues, you have really, been very, very helpful for a very fruitful discussion. I'm really very grateful to you, and also to the audience for bringing out so many aspects of, the way forward for pharma and healthcare. And wishing you all the best, and please stay safe with you and your families. Thank you. Goodbye.
Thank you,
Thank you,
Dr.
thank you,
Rashmi,
everyone.
and all my panelists. Thank you.
Thanks. Bye.
Thank you so much.
Yeah, thank you all and stay safe. Thank you. Bye-bye.
Bye.
Bye.